We are continuing through this issue of JAVMA, May 1st, 2014. We're looking at type 2 errors and statistical power in reports of small animal clinical trials. And for those of you who watch this channel will know that a common theme of a criticism that I have of these papers is that they never have enough animals in their study. And so this is what this paper is talking about. So yay, congratulations, this is awesome. Study comes out of University of Pennsylvania in Philly. The objective is to describe reporting of key methodological elements associated with type 2 error in published reports in small animal randomized controlled trials and to determine the statistical power in a subset of randomized controlled trials with negative results. The sample size are reports of parallel group clinical randomized controlled trials published in 11 different English language veterinary journals from 2005 to 2012. Results found that 18% stated a primary outcome, 22% reported a sample size calculation, 9% included a confidence interval around the observed treatment effect. Reports of only 0.8% of randomized controlled trials included all three of those elements. Among 103 two-group randomized controlled trials with negative results, only 14% and 39% were sufficiently powered, meaning they had a beta of less than 0.2, to detect 25% and 50% relative differences in outcome between treatments, respectively. Conclusions and relevance. The present survey found that small animal randomized control trials with negative results were often underpowered to detect moderate to large effect size between study groups. Information needed for critical appraisal was missing from most reports. The potential for clinicians to base treatment decisions on inappropriate interpretations of these trials is worrisome. Design and reporting of small animal trials must be improved. Boom. Drop the mic. Introduction. Well-planned randomized clinical trials is generally accepted as the best study design to assess comparative treatment efficacy despite internal safeguards against systematic error. Random controlled trials are subject to imprecise results owing to random errors, particularly when sample sizes are small. Two types of random error can occur. When a trial finds no difference in outcome between treatment groups, clinicians must be able to assess the likelihood that an important difference was missed because of type 2 error. The probability of making a type 2 error is represented by beta, but is more commonly expressed in terms of power, which is 1 minus beta. Power indicates the probability of obtaining a certain set of statistical results given a certain sample size. When planning a trial, investigators should pre-specify the primary study outcome and the minimal difference in outcome, which is treatment effect, between groups they consider clinically relevant. A calculation can be performed to determine the sample size required to have a reasonably high power of detecting the smallest relevant treatment effect if it exists. By convention, studies with less than 80% power, which is beta over 0.2, are considered to have excessively high risk of false negative results due to type 2 error. For a given treatment effect, sample size and power are directly related. A larger sample size will have greater power to detect the effect and vice versa. Similarly, when power is set, like at 80%, the required sample size gets larger as the treatment effect of interest gets smaller. In veterinary medicine, clinical trials involving small animals often have small sample sizes and methodological shortcomings that indicate inadequate planning. Boom. Consequently, many randomized controlled trials have lower power from the outset to detect important treatment differences. If an underpowered study finds no significant difference between treatment groups, the results are inconclusive because an important treatment effect has not been ruled out. When a trial with a negative result fails to report power or a measure of precision, meaning confidence interval, around the observed treatment effect, the likelihood of type 2 error is unknown and the results are not interpretable. To clinicians with only a basic understanding of biostatistics, randomized controlled trials at risk of type 2 error will still be considered definitive evidence based on randomized design alone. The relative scarcity of small animal randomized controlled trials heightens the concern that unsubstantiated interpretation of trials with negative results could go unchallenged for years, during which time many animals could be denied potentially beneficial treatments. I mean, really very well written. That's exactly right. Results. During the 8 years of review, 240 reports of parallel group clinical small animal randomized controlled trials were identified in 11 journals. Overall, 84% of trials studied dogs, and the remainder studied cats. The median number of study subjects was 40, which ranged from 10 to 445, and the median number of parallel study groups was 2, ranging from 2 to 6. Of the 240 trials, results were classified as negative in 69%, positive in 30%, 1% were excluded from further analysis because it was not possible to determine the direction of results. A primary outcome measure was clearly specified in 32% of trials. It was explicitly stated in 42 trials, was derived from an a priori sample size of power calculation reported in 22%. A confidence interval around at least one treatment effect was reported in 9% of trials. Trials with positive results and trials with negative results both enrolled few subjects and were unlikely to specify a primary outcome, report a sample size calculation, or conclude confidence intervals around the treatment effects. Reports of only 2 out of 238, or 0.8% of trials, one with positive results and the other with negative results, explicitly stated all 3 methodological elements. Only 14% and 40% of trials had at least 80% power to detect 25% and 50% relative differences respectively between study groups. The median power of all 103 trials to detect a 25% effect size was 20%, and the median power to detect a 50% effect size was 62%. Only 14 out of 103 trials made any statement considering the possibility that the study missed a clinically relevant treatment effect. Discussion. The study documented 2 main issues. The first was that small animal trials with negative results were frequently underpowered to detect moderate to large relative differences in outcome between treatment groups. The second was, The second issue was of perhaps greater concern of underpowered studies where critical information was missing from the published manuscripts. These findings suggest that many randomized controlled trials with apparently negative results are in fact inconclusive or cannot be meaningfully interpreted. Inappropriate changes in patient management could occur if readers misinterpret the results. Most of the trials with negative results in this review had sample sizes that were too small or reliable. Hold on one second. Were too small to reliably identify a 50% better outcome in one group relative to the other according to conventional standards of significance. Therefore, the potential for these studies to miss a clinically relevant treatment effect due to type 2 error is quite high. It is not clear that authors recognize this problem given how few reports contained any statement considering whether the study could have missed a meaningful effect. Treatment effects of over 50% are no doubt clinically relevant. However, in most instances, it would be unreasonable to expect them to exist. Treatments with very large therapeutic effects are likely to be identified through clinical observation or less stringent methodologies. Clinical trials are most often used to test treatments of controversial efficacy, which cannot be expected to exert more than moderate treatment effects. Some authors have argued that underpowered trials are still valuable because they can be combined with systematic reviews or meta-analyses. However, this is only true if a study is otherwise free of major biases and key methodological elements are clearly reported, which they are generally not. Other authors have raised concerns that underpowered trials are unethical because they monopolize resources, inconvenience the study participants, and deprive patients of potentially beneficial treatments, but do not meaningfully inform clinical practice. Investigators can avoid these ethical quandaries by adhering to recommended standards of study design and reporting, such as outlined in the Consolidated Standards of Reporting Trials statement. This statement recommends that all trials explicitly define a primary outcome and describe how the sample size was determined, including all elements used in calculations. And a priority power or sample size calculation indicates that investigators purposely considered the primary outcome and the size of the effect that would be clinically important. It is also provides the safeguards that investigators do not abandon the original hypothesis and shift their attention to questions whose answers appear most favorable once the data is obtained. Even so, reports of several studies included a sample size calculation but then failed to report the results of the outcome on which the calculation was based. Others indicated that a calculation had been performed but failed to provide any details, such as what outcome or treatment effect is based on. And other studies did the same report as this one did from 1989 to 1990 and 2006-2008. In reviews of human subject randomized controlled trials, larger sample size is both an independent predictor of positive study outcome and is associated with higher overall methodological quality. The Consolidated Standards of Reporting Trials group also recommends the author report the numeric outcome for each treatment group as well as the measure of the contrast between groups, meaning the treatment effect expresses a difference in means or as an odds ratio or hazard ratio with a surrounding confidence interval. This approach provides more information than arbitrary dichotomy of significance because it identifies a range of possible treatment effects supported by the data. The confidence interval includes an effect size that would be considered clinically relevant. The result is considered inconclusive rather than negative. Confidence intervals were rarely reported around the effect size among the randomized controlled trials in this review. Many authors of trials with negative results noted that their studies' small sample sizes were a limitation on the results, without expanding further on why this should be so. A few authors misleadingly stated that if the sample size had been larger, the significant result they desired would identify be evident. Wow. Large sample size is not the only way to increase power. Study hypothesis, the effect of interest, the format of the data, meaning like dichotomous versus continuous, and statistical tests used are just a few examples of design and analysis choices that could consider to increase power. So excellent. I mean, excellent calling out papers. I've been complaining about this for a long time. And so for veterinarians and for pet owners, don't ever take a new study just for granted. You have to look into the details of the study, what the strengths and weaknesses are. You can't just read a paper online or whatever and say, oh, this is now the standard of care. Most papers are not up to the level that we should be changing our treatment options and recommendations for these pets. It's as simple as that. So that's it for that issue of JAVMA. We'll start our next one tomorrow. Thanks.